So good morning to everybody, and thank you for offering me the opportunity to present these two studies related to the approaches of gene addition therapy and thalassemia. And in particular, I will discuss with you the results that have been obtained in patients followed up to 8 years after the gene addition therapy procedure, as well as also the quality of life results that have been obtained. Thalassemia is an hereditary disorder in which there is either reduced or even absent production of the gamma chain, of the beta chain of hemoglobin, this resulting into a relative excess of the alpha chain that leads to both ineffective erythropoiesis and short life duration for the erythrocytes. Patients with transfusion-dependent thalassemia needs to be regularly transfused, I would say around 3 weeks for staying alive, and they also need to receive iron chelation therapy to prevent the occurrence of organ damage related to the iron accumulation, which is mainly due to the transfusion, but also to an increase intestine absorption of iron. And despite the optimization of the transfusional regimen and the availability of oral iron chelating drugs, these patients on the long term are exposed to the risk of developing complications including liver fibrosis or cirrhosis, cardiac arrhythmia or heart failure, diabetes, and other endocrinopathies. So there is a desperate need for potentially curative treatment that till a few years ago was only represented by an allogeneic stem cell transplantation, with the limitation that only a minority of patients have an HLA identical sibling, and the risk of transplant-related complications is particularly high in patients above the age of 14. What is the gene addition therapy we are talking about? I like to briefly summarize, thanks to this cartoon, the type of approach that has been developed. In particular, beti-cel is an ex vivo gene addition therapy for these patients, enabling the production of adult hemoglobin at levels that may eliminate the need for regular erythrocyte transfusion. The patient journey is characterized by the initial mobilization of the hematopoietic stem cells into peripheral blood thanks to the combined action of GCSF and another agent called plerixafor. The cells are collected, selected, and then genetically modified with a self-inactivating third-generation lentiviral vector. Once that the drug product has been released, the patient is prepared with a busulfan-based myeloablation, and then the cryopreserved, genetically corrected hematopoietic cells are infused. Remarkably, as you can see in this cartoon, And the beta chain deriving from the genetically corrected cells, there is an amino acid substitution in position 87, allowing to precisely quantify the contribution of the genetically modified cells to the entire production of hemoglobin. This said, let me briefly present the results of the two studies. The first one involved 63 patients with transfusion-dependent thalassemia that were followed up to 8 years after the infusion of the beti-cells. And you see in this cartoon that the patients initially entered the 2-year follow-up studies for them being enrolled into the long-term follow-up, and the data cutoff is July 22. The primary efficacy outcome was transfusion independence, defined as a weighted average of at least 9 grams per deciliter of hemoglobin without any transfusional support for at least 12 months. And this cartoon clearly demonstrates the efficacy of the approach that was independent of the patient age. Indeed, you can appreciate that the gene addition therapy was successful in adults, adolescents, and also in a pure pediatric population. And the study that we are discussing included both patients enrolled in the phase 1 and 2 trials and in the 2 phase 3 trials. And remarkably, the success rate in the phase 3 trial was 90% in comparison to the 68% of the phase 1 and 2 trials. And this is due to the optimization or refinement, if you wish, of the cell transduction. Indeed, through a refined approach, the percentage of transduced cells and the vector copy number per cells increased significantly in the phase 3 trials in comparison to the phase 1 and 2 one. This cartoon also showed that the efficacy of the approach was independent of the patient genotype. In particular, you can appreciate that there was a very high success rate in both the non-beta-0, beta-0 patients, namely those patients with the residual endogenous hemoglobin production in the order of 2.5-3 grams per deciliter, as well as in the beta-0 population, namely in those patients in which there is a virtual absence in the production of hemoglobin. And the data on the beta-0 population have been published in the New England Journal of Medicine. The safety profile of the approach was consistent with that of an autologous transplant preceded by myeloablation based on the use of busulfan. 12% of patients develop a veno-occlusive disease of the liver, which resolve after appropriate treatment. And remarkably, in the thalassemia population, no malignancies, insertional oncogenesis, vector-derived RCL, or clonal predominance were observed. So overall, these data indicated that beti-cel, the gene addition therapy approach, is potentially curative in patients with TDT across ages and genotypes through the achievement of transfusion independence with abnormal or near normal hemoglobin levels. The data obtained in the patients with the longer observation time indicated that the therapeutic benefit is sustained over time, and the two posters you can appreciate that an exploratory multivariate analysis demonstrated that the percentage of transduced cells was the most predictive factor for transfusion independence. Briefly, the second study refers to the long-term patient-reported outcomes following the gene addition therapy, and it will be presented as a poster, and the number is 3665. In particular, we evaluated the patient-reported quality of life, comparing the results that have been obtained before the gene addition therapy and those reported by the patient after the treatment, using a generic health-related quality of life assessment. As you can observe in these slides, there was a positive trend observed in patients who achieve transfusion independence for several factors. In particular, 93% of patients were either employed or able to seek employment, as compared to a value of only 67% before treatment. The percentage of absences from school was only 50% as compared to 95% before treatment. 45% of patients no longer require management of disease symptoms, and 81% reported improvement in physical activity. So overall, all the patients reported an overall benefit from the treatment, and these data indicate that the long-term study of the quality of life indicate an improvement despite the relatively high baseline score, and this improvement continues through the 3 years following treatment. And it is noteworthy the improvement in the ability to engage in employment, school attendance, physical activities that were recorded. Thank you.